Good evening, students. In this class, I'll be explaining about alcohol metabolism and fatty liver. So in this class, you'll be learning how alcohol is metabolized in our body and what are the biochemical alteration which occur in alcoholism. In chronic alcoholism, what are the organs which will be damaged, and one of the organ is liver, and what are the liver changes which will be seen in alcoholic patient. That is, we'll see little bit in detail about fatty liver. Then we'll see about investigation in alcoholism and what is the treatment. So these are the things which we are going to see in this class. Starting with alcohol metabolism, once a person consumes alcohol, it will be absorbed from the intestine, and once the alcohol is absorbed, 90% of the alcohol will be transported to liver. The remaining 10% will be excreted by breath, sweat and urine. So this 90% of the alcohol which is transported to the liver will be metabolized in the liver. So why it is getting metabolized? Because we are not able to store the alcohol in liver. So let's see how it is metabolized in liver. That is how alcohol is metabolized in the liver. So the major alcohol which is consumed by us is ethanol. So we are going to see only ethanol metabolism. That is in alcohol metabolism, ethanol metabolism. So when a person consume normal concentration of, that is moderate concentration of alcohol, all this alcohol which is transported to liver will be metabolized in the cytoplasm. This is called as cytoplasmic ethanol metabolism. That is how the ethanol alcohol is metabolized in the cytoplasm of the liver. When a person consume very high concentration of alcohol, then that excess amount of alcohol will be metabolized in endoplasmic reticulum. So when a person consumes high concentration of alcohol, ethanol, that excess ethanol will be metabolized in microsome, that is in endoplasmic reticulum. So in alcohol metabolism, you have to write under cytoplasmic alcohol, that is ethanol metabolism, and microsomal alcohol, that is microsomal ethanol metabolism. So let's see first cytoplasmic ethanol metabolism. So once a person consumes alcohol, that is ethanol, this ethanol will be absorbed and it will be transported to liver. So in liver, we have an enzyme called as alcohol dehydrogenase. So as the name suggests, it is going to dehydrogenate the ethanol, alcohol. Okay, that is, it is going to oxidize the ethanol, result in formation of acetaldehyde. That is, its corresponding aldehyde will be formed. Okay, so during this process, the enzyme is going to dehydrogenate the alcohol. That hydrogen which is removed from the ethanol will be transferred to NAD, result in formation of NADH2. So when ethanol, alcohol is metabolized, one NADH2 will be formed in the first step. Now this acetaldehyde will be acted upon by the enzyme aldehyde dehydrogenase. Okay, this enzyme is also going to dehydrogenase the aldehyde, that is acetaldehyde. When we dehydrogenate the acetaldehyde, it will get converted to form acetic acid. That hydrogen which is removed will be taken up by NAD, result in formation of NADH2. Okay, so we have two steps. In the first step, we had removed hydrogen which is captured by NAD, result in formation of NADH2. That is, ethanol will get converted to form acetaldehyde, and in the second step, acetaldehyde will get converted to form acetic acid. The second step also, we are going to dehydrogenate it, result in formation of NAD to NADH2. Okay, so at the end of the second step, acetic acid is formed in ethanol metabolism. Now this acetic acid will get converted to form acetyl-CoA by the enzyme acetyl-CoA synthetase. This acetyl-CoA will enter TCA cycle to produce NADH and FADH, which will enter electron transport chain to produce ATP. So this is how ethanol, commonly consumed alcohol, will be metabolized in liver in our body. So when a person consumes excess amount of ethanol, that excess amount of ethanol, alcohol, will be metabolized by microsomal ethanol metabolism. Okay. So let's see how this microsomal ethanol metabolism occurs. So in microsomal ethanol metabolism, instead of alcohol dehydrogenase, which acts on ethanol, here cytochrome P450 will act on ethanol to dehydrogenate, result in formation of acetaldehyde. So instead of alcohol dehydrogenase, here you are having cytochrome P450. So it is going to dehydrogenate the ethanol. So that released ethanol will be taken up by NADP. It's not NAD, here it's NADP. Resultant conversion of NADP to NADPH2. So this is the first step. Once acetaldehyde is formed within the endoplasmic reticulum, that is within the microsome, it will move out of the microsome, that is it will move out of the endoplasmic reticulum, and further step will occur in cytoplasm. So acetaldehyde, now it's moved out of endoplasmic reticulum. Now it has entered cytoplasm. Now we have the same enzyme, that is aldehyde dehydrogenase, is going to dehydrogenate this acetaldehyde to form acetic acid. So the second step is done by the same enzyme which we had seen in the metabolism of ethanol in the cytoplasm. Okay, acetaldehyde will get dehydrogenated to form acetic acid. That released hydrogen will be taken by NAD, resultant formation of NADH2. Next, acetic acid will get converted to form acetyl-CoA by the same enzyme acetyl-CoA synthetase, and this acetyl-CoA will enter TCH cycle to produce NADH and FADH, which will enter electron transport chain to produce ATP. So only the difference between the microsomal ethanol metabolism and cytoplasmic ethanol metabolism is the first step. So in case of microsomal ethanol metabolism, the first step is done by cytochrome P450. In case of cytoplasmic ethanol metabolism, it is done by alcohol dehydrogenase. So that's the only difference between these two metabolism. So we had seen about the alcohol metabolism. Next, we'll see what are the biochemical alteration you will see in alcoholism. So let's assume a person is consume very high concentration of alcohol, that is ethanol. So in the alcohol metabolism, in ethanol metabolism, we have learned it will be transported to liver. In liver, it will undergo dehydrogenation. That is, ethanol will be acted upon by alcohol dehydrogenase to get converted to form acetaldehyde. And this acetaldehyde will get converted to form acetic acid by aldehyde dehydrogenase, alcohol dehydrogenase and aldehyde dehydrogenase. So when there is increased consumption of ethanol, there will be increased formation of acetic acid. This acetic acid will get converted to form acetyl-CoA, which is going to enter the TCA cycle. So from the TCA cycle, lot of NADH will be produced. So if lot of NADH is produced, what will happen to the concentration of NAD? All the NAD are getting converted to form NADH. So NAD concentration will be reduced and NADH concentration will be increased. So this is what which is mentioned in your book as decreased NAD to NADH ratio. That is, NAD concentration is reduced. Why it is reduced? Because of increased TCA cycle, all the NAD are getting converted to form NADH. So NADH concentration will be increased. So always remember, there should be a balance between the NAD concentration and NADH concentration. So our system will try to reduce any pathway which is involved in production of NADH when you have a picture like this. That is, when there is a decreased NAD to NADH ratio, then all the pathway which is involved in increased production of NADH will be inhibited. So which are those pathways? Glycolysis, TCA cycle, gluconeogenesis and fatty acid oxidation. So all this pathway will be inhibited when there is a decreased NAD to NADH ratio. So all this pathway will be inhibited. So gluconeogenesis will be inhibited. So when gluconeogenesis is inhibited, patient will be having fasting hypoglycemia. So that's the first clinical feature, important clinical feature seen in chronic alcoholic. That is, the patient will be having fasting hypoglycemia. Fasting hypoglycemia. Okay, because during fasting, gluconeogenesis is the one which is going to maintain the blood sugar level apart from glycogen breakdown. Since gluconeogenesis is inhibited, there will be fasting hypoglycemia. Okay, so that's the first clinical feature. Second, now one of the pathway which is inhibited by this decreased NAD-NADH ratio is TCA cycle. So TCA cycle is inhibited. So acetyl-CoA cannot enter TCA cycle. So acetyl-CoA concentration will be increased. When acetyl-CoA concentration is increased, it will be channeled for other pathway like synthesis of fatty acid, increased synthesis of ketone body, increased production of cholesterol. So when fatty acid synthesis is increased, it will combine with glycerol to form triacyl glycerol. So triacylglycerol synthesis in the liver will be increased. That will result in fatty liver. When ketone body synthesis is increased, it will result in ketosis. And when cholesterol synthesis is increased, it will result in hypercholesterolemia, which will result in atherosclerosis. So the second, third, fourth clinical features are fatty liver, ketosis, and increased chance of atherosclerosis. Now only I told you that when there is decreased NAD/NADH ratio, all the pathway which is involved in increased production of NADH will be inhibited. So apart from this, all the reaction in which NAD will get converted to form NADH will be increased. Okay, why it is like that? Because when we increase this pathway, we can able to convert more number of NADH to form NAD. So we can able to bring back this ratio. So to promote this, we are going to increase the reaction in which NADH will get converted to form NAD. And one of the reaction is oxaloacetate will get converted to form malate, where NADH is getting converted to form NAD. So the enzyme involved in this reaction is malate dehydrogenase. So once the malate is formed, malate will get converted to form pyruvate by malic enzyme. Okay. So during alcoholism, there is a decreased NAD/NADH ratio. So to bring back it to normal, we are going to convert oxaloacetate to malate, and the malate is getting converted to form pyruvate. So pyruvate concentration is increased now. This pyruvate will get converted to form lactic acid, and it will result in lactic acidosis. So why it is getting converted from lactic acid? Because we need to reduce the NADH concentration. So by converting pyruvate to lactic acid, we can able to convert NADH to NAD. So we are reducing the NADH concentration by converting pyruvate to lactate, that is lactic acid, which result in increased formation of lactic acid in the blood, which is called as lactic acidosis. So the next clinical feature is patient will be having lactic acidosis. When the lactic acid concentration in the blood is very high, that is when a patient is having lactic acidosis, it has to be excreted by kidney. Okay, remember in the previous classes we have told you we have a common channel in PCT for excreting lactic acid and uric acid. So the channel will decide whichever the concentration is higher, that will get excreted. So now the lactic acid concentration is very high. So only lactic acid will get excreted in the urine. So uric acid will not get excreted through this channel. So uric acid concentration in the blood will increase. That will result in gout. So that will be the next clinical feature. So these are the biochemical alteration which you will see in alcoholism. So what are the biochemical alteration? There will be fasting hypoglycemia. Patient will be having fatty liver, ketosis, hypercholesterolemia, lactic acidosis, and gout. So when a patient consumes very high concentration of alcohol, that is ethanol, it is going to reach the liver, and there it is going to get metabolized by alcohol dehydrogenase enzyme and aldehyde dehydrogenase enzyme. Remember, the activity of alcohol dehydrogenase enzyme is very high compared to that of aldehyde dehydrogenase. Okay, just for argument's sake, let's assume a person has consumed 1000 ethanol. 1000 ethanol has reached the liver. Okay. This alcohol dehydrogenase can able to convert this 1000 ethanol to acetaldehyde immediately. But it will take some time for this aldehyde dehydrogenase to convert this 1000 acetaldehyde to acetic acid. So it will take some time. So this acetaldehyde concentration will increase in the blood because the activity of aldehyde dehydrogenase is low compared to that of the alcohol dehydrogenase. So this acetaldehyde which is getting accumulated in the blood will cause inhibition of all the excitatory receptors and stimulation of all the inhibitory neurotransmitter receptors. So this will result in depression. So what are the additional clinical features? The patient will be having depression, and due to the increased free radical formation in alcohol metabolism, there will be mitochondrial damage. So what are the biochemical alteration? The patient will be having fasting hypoglycemia, fatty liver, ketosis, hypercholesterolemia, lactic acidosis, gout, depression, and mitochondrial damage due to free radical production. Next, coming to chronic alcoholism. So we are going to learn only what are the organs which is getting affected in the chronic alcoholism. So when a patient consumes alcohol for a very long time, that is in chronic alcoholic, the patient's CNS, nervous system will be damaged, CVS, cardiovascular system will be damaged, lung and liver will be damaged. In case of CNS, there will be memory loss due to neurodegenerative changes. And in patient who is consuming alcohol for a long period of time, the patient will develop vitamin B1 deficiency, that is thiamine deficiency, which is called as Wernicke-Korsakoff's syndrome. So I will be explaining about the syndrome in vitamin B1. That is when I explain about vitamin B1. So for this particular topic, you will learn that in alcoholic patient, there will be vitamin B1 deficiency, which result in neuronal damage, which is called as Wernicke-Korsakoff's syndrome. In CVS, studies has shown that minimal consumption of alcohol can increase the HDL concentration, thereby preventing myocardial infarction. But this is only for minimal consumption of alcohol. But most of the time, the patient will be addicted and the patient will be consuming more amount of alcohol, which result in increased cholesterol concentration, which increases the myocardial infarction. That is, increases the chance of occurrence of myocardial infarction. In lung, due to chronic alcoholism, patient can develop pneumonitis, and in liver, due to chronic alcoholism, patient can develop fatty liver, which can progress to form liver failure, that is cirrhosis. So we are seeing what are the different organ affected due to chronic alcoholism. Next, coming to investigation in alcoholism. The most lab investigation is liver function test. So based on the liver damage, severity of the liver damage, the picture will differ in liver function test. So in case of mild to moderate, the AST-ALT ratio will be greater than 2. When there is a severe damage, then bilirubin levels will be elevated. And in all the alcoholic patients, the GGT level will be elevated in blood. And there will be a decrease in the aldehyde dehydrogenase activity in liver cells, that is hepatic cells and RBC. Apart from the investigation we had seen in the previous slide, we also have to do few other investigation which is required for us to see the clinical features. So what are the clinical features which are discussed in the previous slide? So the first clinical feature is the patient will be having fasting hypoglycemia. So to rule out fasting hypoglycemia, I am going to do random blood sugar level. Second, we are seeing there will be increased amount of acetyl-CoA. So this acetyl-CoA can get converted to form fatty acid. And this fatty acid will combine with glycerol to form triacylglycerol, which will get accumulated in the liver, which result in formation of fatty liver. So to rule out fatty liver, we have to do USG abdomen. Third, we are seeing this acetyl-CoA can get converted to form ketone body, so the patient can develop ketosis. Ketosis is an acid, so there can be an acid-base imbalance. So we have to do arterial blood gas analysis, ABG, and urine ketone body detection. Fourth, we had seen this increased acetyl-CoA can be used for cholesterol synthesis. So when there is increased cholesterol, lipid profile will be altered. So we have to measure lipid profile. Next, we had seen there will be lactic acidosis. So we have to measure serum lactic acid concentration. Finally, we had seen the patient can develop gout. So we have to measure serum uric acid. So these are the other investigation we have to do in patient who is a chronic alcoholic. Next, we'll see about treatment in alcoholism. So for alcoholic patient, we'll give a drug called as disulfiram. When a patient is on disulfiram, this disulfiram will inhibit aldehyde dehydrogenase. So it will prevent the conversion of acetaldehyde to acetic acid. Okay. So when a patient is on disulfiram treatment and when he consumes alcohol, the ethanol will get converted from acetaldehyde, but acetaldehyde cannot get converted from acetic acid. So the acetaldehyde will get accumulated and it will result in flushing, headache, nausea, vomiting, palpitation, hypotension, sweating and dyspnea. So all the symptoms it is going to cause. So this will result in discomfort to the patient. So the patient will not consume alcohol anymore when the patient is on disulfiram. So we are seeing how alcohol is metabolized in our body. What are the biochemical alteration which is seen in alcoholic patient, and what are the organ which is damaged in chronic alcoholism, and the investigation and treatment part of alcoholism. Thank you.